With that, I am pleased to have Professor Tarsney join me on today's session. She's director of the Donnelly Ethics Program at Shirley Ryan Ability Lab in Illinois. She's a faculty member at Northwestern University's Medical and Law Schools, a national educator in healthcare ethics, consent, and decision making. She works with clinicians and care teams on complex real world ethics cases. And she is here today to um, educate all of us on ethics and what we need to do. I know that many of you will probably pose this question in the chat. After today's session, you will receive communication from us. There will be poll questions throughout. Be sure to answer all three poll questions so that we can make sure that we utilize those to get you your CEU credits. But with that, I'm going to turn things over to Professor Tarsney.
Thank you so much, Barb.
Sure.
Appreciate being here with you all to discuss today's topics. And as mentioned, we are plunging into ethics. So understanding and examining the ethics issues and tensions that really do come up during critical conversations. Those can happen with claimants, family members, and others, I'm sure, in your world. But we're going to focus our time today on didactic and case-based discussions, talk a little bit about ethics frameworks, some methods that we use, as well as skills and techniques that could be useful to address some of the tensions, conflicts, and dynamics that can play into critical conversations. Here are our objectives to cover with you all. So we're hoping that you'll be able to recognize how to apply a framework for ethical decision-making during some of those critical conversations, and look for two barriers, two facilitators, essentially how to better and more effectively communicate when it comes to having some of those conversations about tough topics, sensitive discussions with claimants and families, hoping that we'll leave you with some strategies and tools that you can further leverage. So when we think about ethics, these are really the moral principles, right, that govern a person's behavior or activities. And ethical dilemmas in claims adjusting can arise when professionals have to choose between competing values or try to give service to those, right? May have different responsibilities or interests that are at play. And it's often you're considering this under pressure from stakeholders. You're also considering things like your legal requirements and organizational goals. And so all of this can lead to dilemmas, and that can feel like a test of integrity, fairness, kind of commitment to both the insurer and the claimant. So to start things off, as we often like to do in ethics, I want to give you a case to consider. This is a dilemma regarding an information request is the way I would describe this particular topic. And I'm actually going to share with you this case scenario, which is drawn from an article that some folks in my particular ethics program had published a while ago. And this case is not, it's fictionalized. It's an amalgamation of several different types of cases that have come to our ethics consultation service over the years. And I want to share this scenario with you for our consideration. I've put some of the key facts on this particular slide so that you can hold on to these, but I think it's helpful for us to consider some of the other pieces that I will give to you. So this is about Mr. Jones. He is a 54-year-old man who was involved in a motor vehicle crash approximately 2 weeks ago, and he sustained a spinal cord injury and a mild traumatic brain injury during the crash. He is currently an inpatient on the rehabilitation service and has waxing and waning, fluctuating decisional capacity to make medical decisions as a result of his mild cognitive impairments. His wife of 23 years, Mrs. Jones, is his surrogate decision maker for complex medical decisions at this point. And Mrs. Jones has been at his bedside crying. Mr. Jones told staff members that he feels guilty. During the course of treatment, it was revealed that Mr. Jones was having an affair and was involved in an accident when he was with his lover, Anne, who sustained minimal injuries and was discharged from acute care. His wife believed he was out of town and was stunned to get a call from the hospital about the accident. While Mr. Jones was in a confused state, he called out for Anne, and his wife has become suspicious. Mrs. Jones has been coming in regularly to visit Mr. Jones and has now been asking the staff about what happened and who he was with when he had the accident. She has restricted his visitors to immediate family. Their two adult children, Mary and Tim, ages 22 and 20 years, respectively, are unaware of the father's affair, but have also been asking staff members about what's going on. This case has caused angst among the staff. Some staff members identify with the wife and are angry at Mr. Jones. Others believe this is a private situation between spouses and their children and does not have an impact on healthcare. Still others are worried about asking Mrs. Jones to provide personal care after discharge and setting her up for that, when according to some staff members, her marriage may be, quote, based on lies. So family is starting to ask about, let's say, nurses, care managers, and the adjuster. What happened? What was going on at the time of the accident? What do you do about this? And how do you respond? So these are the types of questions that can come up when ethics gets called in, right? Or when you all are involved and you see that there are these types of moral dilemmas before you. I know we don't have the opportunity for you all to sort of engage with this particular question as I would typically try to do in some of my ethics courses, but it would be really great if you could take a moment and just write down what are the key concerns that you have upon hearing this. You know, I think that we have on the next slide this question. So, what concerns come to mind? Maybe jot down on a piece of paper for yourself what are one or two concerns. And then we're actually going to get some time to come back to this particular case at the end of our discussion today so that we can reconsider together what some of those ethics concerns and considerations might be that you would want to address. So I'll give you just a moment to do that, and then we'll move on.
I'm going to jump in real quick. We've had a
Okay.
handful of folks who have mentioned that they're having an echo on their end. I would just suggest that you try to go down to your audio feature on the bottom left and maybe change the audio settings. It should go away. Another participant noted that, so I thought I would just jump in and mention it versus trying to answer all the questions. It's been about 15 people who have had an issue.
Thank you, Barb. Great. So with that in mind, let's jump into some of the ethics frameworks and concepts that we want to discuss today, and then we're going to come back to our case. So when we're thinking about ethics, there are various theories or frameworks that we use to analyze ethics considerations, and that can include a focus on any of these that are cited here. As you may know, I work in rehabilitation medicine, right? So a lot of different areas of medicine, we actually use similar frameworks. But because we're such a team-based sport in rehabilitation, we often see questions that come up around relationships or consequences, right, that we have to consider. The more typical way that and I will say too that in the time of COVID, we had a lot of questions that came up that had to do with what are some rules, what are some processes that we want to put in place so that we're able to attend to some of these gray area issues of what we should do when problems or situations arise, right? So, what should be our way forward, for instance, in the case with Mr. Jones and Mrs. Jones that we considered at the outset? When we consider how to approach those kinds of situations and questions, we often rely on things like the principles of biomedical ethics. In the clinical ethics setting, this is sort of the go-to framework that we use to break down some of these bigger ethics issues that come to us and think about, well, what's really at stake. So we look at things like beneficence, right? How can we provide benefit and balance the risks to bring about the best results? What would the benefits be to Mr. Jones of disclosing this information to Mrs. Jones at this juncture? What would be the benefits to the family unit of doing that? And then what are the drawbacks? What are the burdens that would exist if we were to approach it that way? Respect for autonomy is another key principle in ethics that we rely on. We want to be able to foster self-determination and respect individual differences, right? Individuals' specific preferences. So this might mean, really understanding better what are Mr. Jones' preferences for discharge? Is he able to give us some sense as to what he's expecting or hoping for when he is, getting into that next stage of his recovery? Who is he relying on, right? What are his preferences? That's respect for autonomy. Non-maleficence, doing no harm. This is a sort of a cardinal ethics principle drawn from that Hippocratic Oath, right? That we all want to carry forward. We're here to help benefit patients, claimants, and not to do them harm. So, would harm come to Mr. Jones in this situation? How would we describe that harm, right? How do we think about that? What can we do to help mitigate that type of harm? And then justice, upholding concepts of fairness and equity, right? This is equitable treatment for people, no matter the circumstances that bring them into our care, right? Um, and for which they need that help and support in their healthcare context. So these are the principles that we often look to and try to think about. How can we better balance these? Because sometimes you can't just rely on any one of these. Many of them may be at stake in any given scenario, like is the case in the as is the case in that very first case vignette that I uh, introduced at the beginning. So, when we think about some common ethics issues that come up in care management that we deal with here in rehabilitation, kind of hailing from my context, I can tell you there's lots of them. I just put few key ones here in this slide. Things like decisional capacity, right? Does the patient have the ability to understand and make their own decisions at this juncture? And that's very decision specific, time specific. So, those are really important questions to ask so that they can exercise that autonomy. Surrogate decision making, it's front and center in the case that we talked about here at the outset, right? This really has to do with that whole process of someone stepping into Mr. Jones' shoes, Mrs. Jones stepping in and making a decision on his behalf. And surrogate decision making is a critical bioethics issue that's been addressed by courts and policies and medical practices, right? So most states have laws that say, okay, if the patient doesn't have an advance directive, then this is who we should go to as a default surrogate decision maker. In the state of Illinois, where I practice, there's a hierarchical list of who we go to. First, the legal spouse, first the guardian of the person, then the legal spouse, then the adult children, and so on and so forth until we identify who is that surrogate decision maker for the patient. There are questions about informed refusals or against medical advice discharges. This often comes up in the discharge context, but informed refusals can also come up in the medical treatment context as well. Questions about truth telling, such as with this case. And when we think about truth telling, we more commonly think of things like withholding information from the patient, such as with diagnoses, right, with cancer, or things like HIV/AIDS, as it used to be way back in the day. But that in this particular case that I've offered to you, it's a little bit different, right? It's about personal information that the patient has not told his family and whether that truth should be revealed. So it just depends on the context. There are questions about advanced care planning that come up, and I'm sure you've been involved with not only who people may want to maybe name as their healthcare power of attorney, right? But if they have specific wishes about what healthcare they wish to receive in the future and they're able to make those decisions, we want to give them that opportunity, respect their autonomy to engage in that and make those decisions plain or clear. Such as I've seen some situations where people say, well, if I had to, live long term on a ventilator in a facility, that would not be a good quality of life for me. So I would not want that. Disclosure of confidential information. So this is similar and brought up in the case that we discussed, right? Is this confidential information? How do we disclose that? When should we disclose it, right? What are the sort of the ethical considerations that we'd want to think about? And then goals of care. Like, is this, you know, what goals does this patient have? How can we better meet them? I've seen situations, especially after cancer, and people are here for cancer rehabilitation. We can't make assumptions about these goals, right? These are important things to better understand. And sometimes our patients, the claimants, and the family members are not necessarily on the same page with respect to goals of care. So it's important to look at. And then we also see questions, of course, about end of life decision making that are related to that, quality of care or quality of life issues, and abuse and neglect that sometimes do come up in our setting. So, is it ever okay not to share information, right, requested with a family member who is a surrogate decision maker, similar to this case, but it could be in a different situation. What are some scenarios where this happens? Well, we could consider things like harm to the patient, right? Could the patient, if we were to disclose this information to the surrogate decision maker, would the patient come to harm, such as like abuse, neglect, other concerns that we may have? We could think about this from a patient perspective, right? Does the patient have a specific preference on this? Have they asked us not to share this information with the surrogate? Well, that would change how we would look at a situation like this. We could think about logistically, right? Is it ever okay not to share information with a surrogate? Well, what if that surrogate says, I can't make this type of decision. I really want you to go to this other person. We have to work through the ethics considerations in those situations. And then maybe it's just not really relevant to their scope of decision making, right? And that's kind of a big question that looms large in the case that I put forward at the beginning. Do they need this information in order to make medical decisions on behalf of the patient? These disclosures of confidential or sensitive information sometimes, and is kind of more akin to the case that I mentioned at the outset, these types of disclosures can be tricky, right? So these are good questions to ask. Is there ever a duty to disclose personal health information about claimants to others, right? We often think about this as in that scope context. Again, is it critical for them to understand in order for them to fulfill their role, or in order for them, such as making a decision, or in order for them to fulfill their role as a caregiver? How can we balance our duty of confidentiality and respect for privacy with our commitment to provide sufficient information for medical decision making? We've seen this come up sometimes in cases where, say, the patient has an infectious disease such as HIV, and the decision that the surrogate decision maker has had to make so far about their healthcare has to do with, some type of abdominal surgery where information about infectious disease status was not disclosed. And there's uncertainty about whether or not the surrogate may know about the patient's infectious disease status. Those are questions that kind of come up in this particular vein. And what about the commitment to do no harm, right? We need to think about that and really unpack what harm could transpire. And often I want to just flag for us, as in the case that I mentioned, at the outset, we don't necessarily know what we don't know. And so there's often an obligation to just get better information about this, or to stop and think, is that really a role for us to get more information about this? Ought we instead focus on this other aspect of the patient's care and the case? And then what factors should be considered when disclosing sensitive information? This is something we're going to talk about a little bit later in our time today. So let's take that kind of step back and talk about informed consent, right? This is really the basis that we look to. This is the gold standard. Patients have the right to receive information and ask questions about their recommended treatment so they can make that well-considered decision about their care. And there's critical elements here that the providers, so often the people I work with, need to fulfill, right? We have to disclose relevant information. And we have to make sure that we're giving information to somebody, to the patient, and they're able to make a decision, right? Either that's the patient, or if they're not able to make that decision, then the surrogate would get that information. And we want to also ensure voluntariness. This is a critical element such that the patient's not feeling coerced or um, bullied into making a certain type of decision. I've seen this sometimes come up in my practice when patients are making refusals of treatment. And when we sit down with them and really give them some time to unpack what their concerns are, we're finding out things like, well, their spouse said that they wouldn't, take them home if they were on this type of medication. Things like that, where that might not be the patient's own free will or voluntariness that's affecting their decision in that regard. So these are important to think about when we think about this kind of big concept of patient rights and consent. And then medical decision-making capacity. This is important, right? So just this tests the ability to make that decision. This is the standard, is that medical decision-making capacity is the ability of the patient to make their own medical decisions. This capacity is kind of that basis that under that framework and under foundation of informed consent. because patients with capacity can consent, go on to consent to medical care with the relevant information and with the right voluntariness, or they have the right to refuse, right? Unwanted, even life-saving medical care. And this has been established by the courts as well as in the realm of ethics in which I work and get to be. So we'll move right along to medical shared decision making. So this is really what we're all trying to achieve, right? By giving patients informed consent, we want them to really be able to engage in a process of shared decision making. So it's kind of the how for how these decisions then end up getting made once we know that they're able to provide that informed consent, or the how behind informed consent. And the secret sauce here, I always try to say, is to get to that middle portion there, right? So in rehabilitation medicine, like many other areas, there's a real biopsychosocial context in which all of these decisions are being made, right? That's sort of the backdrop of everything. And the patient is bringing to these decisions, to these conversations, their goals, their preferences, right? And clinicians are really bringing their evidence, their expertise, and weighing in on, what they think would be a recommendation or what options the patients slash families might have in certain situation. And so as these things all come together, in this middle is really that opportunity for shared decision making, which is not just an event, but a true process that unfolds, which has regard for both the patient's expertise in their goals and preferences, their values, as well as the clinical expertise in the setting of this biopsychosocial context. And when patients don't have the ability to consent and really engage in that full shared decision making, we still look to them to assent, right? And assent really means here where we're like actively soliciting their agreement. That's how we think about it in this clinical medical context. So I like this visual because it shows you the overlapping process pieces that exist both in consent, when you're able to go in that direction with patients and they're actively engaging in that hopefully shared decision making, and assent, where their agreement is actively solicited. So in both instances, we're really trying to give appropriate information, right? Relevant information. And sometimes with assent, it's appropriate levels of information sharing that they have the ability to engage with. We want to make sure in both of these instances that we are understanding their preferences, right? That they have that opportunity to engage and provide that information. And then, where helpful, especially since so many of these decisions are impacted by their goals and their values, we want to clarify those pieces so that we're able to kind of move things forward in that process of assent as well. Great. And then, usually in law and in ethics, we operate in a Western context. And so it is very typical for us to look to just that patient as the center, right, of decision making, and focus on the individual, and then kind of have the family as, an adjacent but maybe separate entity. However, there is a doctrine in ethics that really talks about the fact that there's this concept of relational autonomy, right, which says that the patient's um, you know, outlook, their perspective is naturally shaped by their close social relationships. And it's very uh, logical that they would help to shape what those preferences would end up being. And so, therefore, healthcare decision making is naturally influenced and not unduly influenced by family members, maybe motivations or concerns. It's almost akin to looking at things as more of a unit in a holistic way in terms of what those preferences would be and attending to that. So I've seen cases from an ethics standpoint where we might have a patient who says, I really need my adult child to be with me for this conversation. And they might be as explicit as that and calling it out, right? Or it might be a situation where we need to make some space for that, and really inquire more about whether they would like to have other family members with them as part of this unit of decision making, or if they are sharing in this process with other family members, that would be important to include. And sometimes too, asking them like what part of their, how is their perspective shaped? And if they're giving you that information back about it being shaped by those family members' concerns and motivations, seeing if there are opportunities to bring them in so that everybody can get on the same page with the information shared. So, in terms of surrogate decision makers, I want to kind of move us into this realm of thinking about that role of that surrogate, right? So, these are situations where the patient, unfortunately, lacks the decision making capacity to make a certain decision. And so then law and ethics tells us, okay, we go to that surrogate decision maker. And that surrogate decision maker has a standard that they're supposed to use to make those decisions, and it's called substituted judgment, right? So they're instructed to make the decisions as he or she believed the patient would if they could. We do know from the psych literature and just from experience that this is a tough putt sometimes for surrogates, right? It can be particularly hard, I think, in our setting of rehabilitation when you have surrogates who are making not only making these complex choices such are laid out here, there's many more. I've just profiled a few on here, but, when they are not only making complex choices with a variety of options, and there's a lot of information that they have to digest, and their family member's been through a crisis, but it's also evident that that they have multiple roles. So they might be a caregiver for that particular patient when they come home, right? As well as a surrogate decision maker. And that puts a lot of pressure on them in terms of carrying both those roles as they are thinking about kind of evaluating some of these complex options and choices that are before them in the rehabilitation context. And these are just a few, examples of some of those complex choices that they may need to engage in. And then I also want to be sensitive to, calling out the complexities in the rehabilitation setting, right? We have patients who are sort of regaining capacities and coming back into the picture to make those decisions because we have a longer length of stay. And as I say to many people when I'm teaching the med students, people here are regaining their functional abilities. Oftentimes that means they're also regaining their ability to make decisions. And we need to provide some space for that and engage with patients in a way where we're really giving them opportunity to weigh in and give us what they are understanding the situation to be. We certainly need patient engagement and rehabilitation. We're asking people to do therapy, so as we're engaging with them, we need to give them space and understand what they are giving to us as well in terms of their preferences. Decision questions loom large at the outset of rehabilitation. This is just a function of rehabilitation. Our pathway is something that we need to start working on almost as soon as patients get here. And that can be hard to understand because for people who are not accustomed to, right, the medical context or working in healthcare, it seems as though we're already talking about the endpoint when they are first just getting into our space in rehabilitation. So there's a lot of education and again, providing, I think, some opportunities to engage in that shared decision making and goal setting that really helps to then flesh out how discharge plays into this whole process. And then, of course, we have a very multidisciplinary team model. So rehab's the ultimate team sport, and we have a lot of people who will be giving the patient and families a lot of information and who will also be receiving a lot of information from the patients and families. So naturally, when you have such a team sport and this type of model with a lot of different kinds of decisions, right, over a long length of stay, you're going to get some conflict sometimes. Differences of different perspectives, right, which can feel sometimes like multiple truths, as is laid out here on this particular in this particular comic. But what I really underline is, conflict is present more often than I think a lot of us would like to admit or identify. And it's my view that identifying and addressing that conflict can really be important, especially if we can bring skills, techniques, kind of a method to help sort through the messiness, right? And get everybody onto hopefully a better page. So it's important to remember in these contexts, like patients and their families may have conflict between them. Family members may have conflict between them. Team members may have conflict between them, right? And all of the above, there may be kind of different perspectives, different opinions and views of what could be most helpful. So I'm going to give you a moment here for poll question 3. Great. So not only do we see conflict kind of percolate in cases, we know this is also part of everyday life here, right? And I want to talk to you about something that I call the core concerns framework that I think is helpful when we're sorting through conflicts, especially conflicts that, raise questions that relate to the big E, emotions, right? Or that raise up these emotions, right? We're talking about difficult situations similar to the case that I presented at the outset, where people may have a lot of different emotional reactions to the questions that they find themselves posing to one another, and the conflicts that they might find themselves in the middle of. And this framework is drawn from the program on negotiation at Harvard, and alongside Daniel Shapiro, who's a psychologist. They have this framework where they say, well, it's natural for us to have emotion when we're in the midst of some of these conflicts, right? And have different perspectives. And if we can just attend to 5 matters that we really care about, we'll have a greater chance of success in terms of reaching some type of a resolution to said conflicts. And that's the core concerns framework that they present. I feel that this is particularly useful to me in my practice and rehabilitation because if I can center on 1 or 2 of these at any given time as conflicts are kind of percolating, or even if they're in kind of, their full full bore conflicts that I'm attending to, if I can just hold on to some of these things, I have a much easier way of facilitating communication between people that can lead to a better resolution of the situation before us. So the first of these is express appreciation. That's really preparing to appreciate others and helping others appreciate you, right? So these are some of the techniques that we're familiar with, I think. Active listening, listening for that context and those sort of meta messages behind it. Maybe engaging in a role reversal, asking open-ended questions instead of closed set questions to make sure you understand this, right? So with Mr. Jones, why does he feel guilty, right? Help me understand, why are you feeling guilty right now, right? Let's not assume, and try to appreciate what his perspective might be. And then asking others to appreciate you, sometimes with like a time limit, and just saying, I just want to limit myself to a few big points here so I'm able to, articulate this as well as I can. And when I'm in the midst of mediating this between folks, I ask them, could you give us, your concerns, just 2 points that you kind of had the greatest concern, or 2 points of greatest concern, so that we can address those pieces. In those ways, we can help kind of facilitate and move things along. Also building affiliation or connectedness, right? So in my situation, these are some of the techniques I bring to kind of bring this concept to life. It's reviewing that chart ahead of time, building links, starting a discussion along points of commonality that I see that exist. Maybe even simple things like logistically setting up times to connect, right? And if I'm asking someone not to be present for a conversation, I'm going to try to exclude them with care and kind of keep them abreast. We're going to discuss this and then we'll come to you and have a chance for us to have a conversation about this. So this type of affiliation and building affiliation isn't manipulative. It's really with the end goal of creating a process and a context in which people's perspectives can be heard. Respecting autonomy is one that ethicists love, of course. And this really means, kind of in this sense of conflict resolution, thinking about opportunities to establish decision-making guidelines, right? When are you going to inform people? Whereas when are you going to come to them and ask them for a joint agreement? So is this the type of situation where you're going to keep people abreast of things and come back and let them know what's going on? Or is this one where we're going to sit in joint session and really hammer out a joint agreement? You need to decide who to invite input from and who to inform about this. And sometimes you need to give away your own autonomy, right? Limiting your autonomy can say, I'm not the one making a decision here. It's for you two to get on the same page, and seeing if that can help drive things forward, especially at given points. Acknowledging status. So patients, for instance, have high status when it comes to their goals, like what motivates them, right? What their values are, what are their religious preferences. They have high status about that. We don't as healthcare providers. Healthcare providers have high status in other areas, right? So recognizing status, asking them to flesh that out or explain it further, helping people appreciate your areas of high status if you're in the midst of that particular negotiation, and using checks and balances to avoid those status spillovers. Sometimes I think about this too, is doing some of my homework ahead of time to make sure I understand where people might be coming from, but then ensuring that there's room for me to understand that further. Why do they have this expertise? Why are they so kind of committed to this particular course? And status is not fixed, it can be acquired over time. Choosing a fulfilling role. So this is something that, we typically, I think, tend to naturally do if you think about some of those close personal relationships you have with a best friend or, a partner. You might engage as a listener, you might engage as a problem solver, you might play a devil's advocate. These can be helpful to kind of move conversations that are mired in conflict a little bit forward and say, help me brainstorm. Are these the only options that we really have in front of us, right? Um, those are some key points that you can hold on to. So that is the framework for core concerns. And attending to these core concerns, in my experience, has really helped to make space for conflict resolution when we find that people have differing perspectives that would be well served from unpacking further in order for us to move things forward. So now I want to go back to our case that we discussed a little bit at the outset, right? Again, we have a 54-year-old man, Mr. Jones. He has both a spinal cord injury and traumatic brain injury from a motor vehicle accident. He is now inpatient. His decisional capacity is kind of going up and down, but he's making some simple decisions, but he's not making complex decisions at this particular point in time. His wife of 23 years, Mrs. Jones, is his surrogate, and the staff, the team members are aware of the fact that Mr. Jones is having an affair. The wife and children are not aware of this information. So there are differences in terms of information that people are holding on to, right? And you're getting ready to think through this discharge planning. The patient is currently assenting. He's agreeing to go home with his wife, and the wife is there making preparations for doing this. The adult children are also coming into the context, but now they're starting to ask the nurses, care managers, others, what happened at the time of the accident? So questions about what do you do? So given what we have discussed to date, I'm wondering if you can take out your notepad and look at some of the concerns that you had highlighted at the outset and think to yourself, are there new ones? Are there things that you would add to this? Or really like questions that you have now where you would like to get better answers, for those questions so that you could think about how to move the situation forward, right? So I'm just going to give you a moment to do that. And then I am going to provide to you some different, since we don't have the chance to engage with each other as much as I would hope, I'm going to provide some, um, you know, some concerns that I've heard from others, some questions others have raised with me in these contexts. So, sometimes I've had people say to me, okay, well, Professor Tarsney, this is really, not in the scope of the team members to disclose. They have professional responsibilities. They, need to keep this information to themselves because it doesn't have to do with Mr. Jones' critical healthcare needs at this moment in time or decisions that are before Mrs. Jones. Might be different if Mrs. Jones wasn't showing up, right? If she was like, I don't know if I'm in for this, this surrogate role, I'm not sure it's for me. So if she was more ambivalent, maybe then we would kind of explore that further and think about, gosh, should we be giving her this information? Should we help Mr. Jones to talk to her about her role as a surrogate? But seems Professor Tarsney like she's occupying this role. So why would we go ahead and maybe do this? Because although it would be truthful, wouldn't we cause harm? What about that risk of harm, right? To Mr. Jones and to the marital relationship here, right? And I've heard others say, well, no, 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 no. You're not thinking about this, the whole picture here, right? We need to think about it in a more holistic way. The unit of decision making is sort of the family unit in this case, because she's taking on the role of surrogate, but it's the family that's going to be caring for him here. And they're asking questions about this. So maybe we need to give them options for how to address this situation. Maybe we need to consider consulting a psychologist and having them come in to talk to Mrs. Jones because we're responsible for her too. She's part of this unit. We want to make sure she's prepared as a caregiver to take Mr. Jones home because it doesn't help us if she gets home and then discovers all this information and then, it's going to come out at some point, right? And if she just backs out of the discharge plan before he's ready to discharge or, doesn't want him at home anymore, then how have we served him well, right? So let's bring in a consultant, let's bring in a psychologist, let's have them talk to Mrs. Jones about what's going on and her need to unpack this further. I've heard others say, well, she's a surrogate. She gets access to the medical record. So maybe we say, we don't have the information, but as a surrogate, you can get information from the medical record. Maybe we tell her about her rights because she's standing in the shoes of the patient and she gets access to that particular information. And she may not be aware of that. She may not be fully knowledgeable about that. Of course, the medical record, as we all know from reviewing these records, does not have everything in it. And so I would caution maybe also a recommendation to let Mrs. Jones know that information so that she's not looking to that as like, the source of truth, right? We can also redirect her. Geez, Mrs. Jones, these questions are natural. You obviously care about your husband. You're here. We applaud that, your commitment to him. We would really recommend you talk to Mr. Jones about this and let us know what we could offer to you in terms of resources or supports that would be helpful in terms of having that conversation. Assuming Mr. Jones is able to kind of, engage in that conversation. Or we tell Mrs. Jones, these are great questions, but this is not our information. We don't know what we don't know. We don't have the full details. And so we would encourage you to talk to Mr. Jones when he's more recovered and further along in his recovery. So these are different ways that I've heard people kind of respond to this information, right? And there really is this tension between kind of the ethic of providing truthful information to Mrs. Jones, right? And yet also doing no harm. And we don't know so many things. We don't know what we don't know about the situation between Mr. and Mrs. Jones before this, right? And how their relationship was structured, whether she knew of things, whether she didn't, whether she had an affair in the past. And I think a good question that's raised is like, what if this happened to Mr. Jones when he was driving, to see Anne? We would know none of this information, but the situation in the marriage might still be the same, right? And his injuries might still be the same. Oh, so we do have a poll question in here. No? Oh, okay. I'm just seeing this from before. Got it. Okay.
Yeah.
So these are additional, considerations. When we get these information requests from surrogates, similar to what I was talking about earlier, these are the considerations, right? We want to think about our patient's privacy, duties of confidentiality. Maybe our patient says, hey, I don't want you to talk to Mrs. Jones about some of these things. If he was kind of less confused, he may be asking us for that, and then we would have that duty. Respect for autonomy and his preferences, asking him again, what would he want in this situation? Does he want some supports? Commitment to non-maleficence or doing no harm, right? So we're talking about that truth-telling versus non-maleficence. And then benefits versus harms. What are the benefits of disclosing this information at this stage? What are those harms? And really weighing those in these situations. These are other factors and approaches that we often consider in ethics, like who would we disclose this sensitive information to, right? In our case here, legally, it is the legally authorized representative, right? That would mean a healthcare power of attorney or that surrogate under the law, if it's not the patient, right? If we can't disclose it to the patient, it's a surrogate. And, things like what? Well, we really, here, the gold standard is we want to disclose minimally necessary relevant information, right? Because information that people would need to make medical decisions on behalf of Mr. Jones, like in our case here, so that they have the appropriate, information to, consider that, right, to have their own consent, to provide consent on behalf of Mr. Jones. But we want to provide it as is minimally necessary at a given time. And, now this is a question where that risk benefit comes into play, right? Do we provide it, these opportunities now? Do we wait until Mr. Jones is more recovered, right? What are the risks and benefits of disclosing it at different times? And then how? These are really ways that we can kind of attend to some of those ethics principles too, right? Of respecting autonomy and doing no harm. We want to do it privately, sensitively, right? Explore their prior knowledge of a situation. Maybe this is something that's done alongside the psychologist for the team, right? Plan those supports and resources so that we can support them through the disclosure if there's a decision that's made that, like, gosh, this is really important to disclose at this juncture to the surrogate. oftentimes too, we from ethics have really worked with the teams to think about how can we support the patient to disclose the information, right? So talk to the patient about it. Say, hey, Mrs. Jones is raising these questions. What do you think about that? And then providing some space to better understand their perspective on it and seeing if it's feasible for us to support them disclosing it if they have an interest in doing so. So this is the article that this case was written up in, and I want to just offer it to you in case you wish to take a look at it. There's a much more fulsome discussion of all the ethics issues that are kind of covered within this case, and there's also great perspectives from different columnists who wrote in to provide their own commentary, their own lens on how they would approach the question of whether to disclose in this particular situation. So I will let you take a quick pick of that or grab that link if you wish to consider it and look at it for later. And then I think with that, we are at the end of my time with you, the formal presentation, and I would love to take your questions.
Great. So, couple things housekeeping wise. The link will be available when they get the slides, and all the attendees will get a email after the session with the slides. I do believe Dana is going to reopen poll question number 2 that
Oh, okay.
people had a difficult time with. We apologize. We created that problem on our end. We were both trying to open it up for you, and we opened and closed it. So you shall all get that. And let me go ahead and read one of the questions. When it comes to sharing information with a power of attorney, such as a spouse, as a work comp adjuster, we wouldn't be obligated to share any info of who else was in the car or why they were in there to the spouse. So, can you give an example of an ethical dilemma an adjuster might deal with compared to a provider?
Hmm. I'm not 100% sure on that context. I can tell you that like when we've seen these situations where there's more of like a duty to disclose that information to a surrogate, it's because it's really critical information for them to know to like think about like that next level of care.
Yeah.
So say it's about like someone's adult parent, their parent, right, who's an older
Hmm.
adult. And so they're trying to make a decision. And so you might have to disclose like we have information from their medical records saying that they really have no funds, that they've disclosed this information, right? So it
Right.
doesn't seem super germane to like, it's not medical, but it might
Right.
affect their ability to, pay for some portion of that next level of care.
Hmm.
And I think that that might be as relevant an example as I could think of. So things that are kind of, really they are relevant at the end of the day to that decision for that next level of care. And it's
Right.
unfortunate when you're in that situation and they didn't know that maybe about their parent.
Right. Well, and even in this scenario, although the work comp adjuster wouldn't be obligated to share the information, they may still be asked.
Yeah,
And they're going to
yeah,
put you in a bad position to,
right.
some of the other participants in the session had some really good suggestions, like direct the person to contact law enforcement.
Mhm.
You can contact law enforcement. They can speak to you about, whatever they might speak to you about, but, that's not really our purview. There was another question that had come in. Let me see. Is it up to the doctor or the spouse slash caretaker to decide if the spouse or caretaker can become the main decision maker if someone has a TBI? Where is the line if it's a mild TBI and Mr. Jones can speak, but you're not 100% sure that Mr. Jones understands what's being asked of him?
Yeah. So this is the decision-making capacity is kind of at the heart of the question you're asking, right? So
Mm-hmm.
if someone has a mild TBI, I've seen it go lots of different ways. Sometimes they have the ability to make their own decisions. They just need more time to process,
Mm-hmm.
supports, they want a family member with them, but they can still make that main decision on their own. So this is where the doctor should be able to give you information about that because this is a clinical determination, decision-making capacity, not something you need to go to the courts for, and not
Right.
something we can just glean from the medical record. So it's one that needs to be really explored with the patient in that real time. So the question would be, hey, I know they had a mild TBI. Now this decision is in front of them. Doctor, can you let me know, does this patient have capacity to make this decision? Or do I need to, connect with, it would be best to have the patient and their surrogate kind of involved in it, right? But
Hmm.
do I need to make sure that that surrogate decision maker is also involved there?
Right.
um, in that discussion. So I think that is really where I would suggest you go, which I know isn't it's very case by case, very situation specific, but that is the
Hmm.
nature of decision making capacity because, again, we want to err on the side of letting people have their rights, right? And not
Right.
relinquishing those or taking those away from them. So the
Hmm.
law basically says, hey, everybody's got capacity unless there's documented evidence, unless a physician has said they don't have capacity. We got to treat
Right.
them like they do.
Exactly. And someone did say, direct them back to their doctor.
Yeah.
Direct them back to
Yep.
the direct for the non-medical things, direct them to the law enforcement. For the medical things, direct them back to their doctor.
Hmm.
Um, it also says, how would you approach a situation in which a spouse has taken control of a patient's medical decisions without formally being assigned as the surrogate, but they're delaying medical treatment from the patient's and the patient's care to progress? I think
Yeah,
that.
these are tricky situations, right?
Hmm.
So it could be that I would investigate further. Is it the case that the patient has the capacity but has said, hey, I want this person, I want this family member to make a decision for me?
Hmm.
You know, if that's the case and you know that to be true, then you are kind of working with them. But I would bring that back to the patient and just say,
Hmm.
we've been working with Joe, but Joe has not been able to make a decision in this regard. And we're really worried because the consequences are to you, Mary,
Right.
So let's have a discussion about whether we want to bring in another surrogate decision maker or others. the
Yep.
the question of formality is, it needs to be documented that the patient doesn't have capacity, or it should be documented the patient doesn't have capacity.
Right.
Who's the surrogate then is sometimes not as well documented in my experience, right? People don't
Hmm.
sometimes identify that. But I think it's a really good question to ask is like, is this the right surrogate decision maker for the patient? Ask
Right.
the teams, right? Ask the
Right.
doctor. Because
Right.
if it's not the right person, it's just the loudest voice. Well, wait a minute. We don't want to have to work with Joe anymore. Right? Legally, ethically, we should work with someone else. So,
Right. Right. That was it as far as questions are concerned. So thank you so much. This was such
yes,
a
my
great
pleasure.
session. If you go to our events page on the website, which is where we will house this presentation and the recording, you will see that we've got a couple sessions coming up, one on neuropsych, one on orthotics and prosthetics, and another one on spinal cord stimulators. So lots of great content coming up. Professor Tarsney, this was fabulous. I'm hoping we can have you back next year. It was fantastic. We had over 1.3, um, we had, 1,300 attendees today. So nice big audience. I know it poses issues because you can't really talk to the people, but you did great.
Thank you. Great to be with you all. Take
Great.
care.
Thanks so much. Take care, everyone.